Okay.
Okay, sure.
Buenas noches. Hoy tenemos un invitado muy especial, el doctor Lax Bandari, él es cirujano plástico. Luego él hizo el fellow en cirugía de mano en el Instituto Kleiner. Luego hizo senior fellowship en el Instituto Kleiner. Y luego hizo otro fellow en cirugía microvascular reconstructiva y craneofacial. Y pues yo me siento muy honrado que todos estos amigos que hemos conseguido a través del fellow vengan y estén con nosotros. Entonces hoy vamos a hablar de lesiones de flexores y Lax nos va a hablar de eso. Muchas gracias. Lax, I was telling to everyone that we were friends, that you were a senior fellow, then you did your reconstructive microsurgery or fellowship in craniofacial surgery. That I feel very proud that you're here with us, and we're talking about flexor tendon injury. So
Yes.
thank you for being with us.
That is not true, sir. That is not true. He said you were the worst, and you were a really bad friend. But he's just he's just lying as always. Well,
lying as always.
Thank you very much for being with us.
It's a pleasure.
It is a privilege to have you here this evening in our academic hour. Welcome, and now we are looking forward to seeing your conference. Thanks for being with us.
No problem. Okay, it says host has disabled screen sharing. Can I have screen sharing enabled, please?
Yes, sir.
Okay.
Juan David, ¿puede dejar a Lax ser el host, por favor?
Doctor, okay. ya lo puse para que compartiera.
Please try again. Gracias. You're ready, Lax.
Okay, let me try. Desktop one, share. 1 second, sorry about this.
You're good, amigo.
Okay, is this visible?
Yes, sir.
All right. Hello, everyone. I am Lax Bandari. I am currently working at Kleinert, and thank you, Jorge, for giving me this opportunity. So I started practice just a couple of years ago, and I'm a junior faculty. So it's indeed an honor for me to talk to you guys, and with the August presence of Dr. Moreno too. So let's talk about flexor tendon injury. And the history, we'll start with history, a little bit of basic science, and the surgical management, etc. So Hippocrates first observed like white slender tubular structures entering skeletal muscles, and he thought they were nerves. Galen was actually the surgeon for gladiators, and he probably encountered a lot of such injuries. But when he repaired it, he noticed that the outcomes were very poor. So he said that the physician should not repair it because that would result in pain, twitching, and convulsions of the limb. Right now, if you think about it, probably he was repairing nerves to tendons, and that's why he was causing all that symptoms. But however, over 15 centuries, Galen's teaching prevailed. Von Hallen in the mid-18th century showed that the placement of suture in canine Achilles did not have detrimental effects. Hunter in 1767 recorded that canine Achilles tendon healed by formation of callus or similar to that seen in healing bones. Let me minimize this. Okay. Bayer and Salomon in 1920 observed poor tendon healing of sutured canine flexor tendon, and Salomon thus advocated to leave a defect in the sheath which allowed contact between repaired tendon and subcutaneous tissue. Even in the 19th century, Bunnell and Garlock observed there was frequent occurrence of restrictive adhesions at the flexor tendon laceration site, and Bunnell thus coined the term no man's land. He observed that there were firm flexor tendon does not allow for the swelling of repair. Blood supply is squeezed out and consequently the tendon within the tunnel undergoes necrosis. This was also observed by another famous surgeon of that time, Boyce. Boyce noted that the primary flexor tendon repair in the critical man's land is usually failed because of infection, scarring, and flexion contracture. And because of generally unsatisfactory result, his preferred treatment was tendon grafting. So Boyce's opinion regarding the poor results following many primary flexor tendon repair was also held by other investigators. So these were like the big surgeons at that time. So Bunnell and Boyce both were saying that no, you should not repair flexor tendon primarily. And they were from like big cities too. At that time, one surgeon from Louisville, Kentucky, he went to the ASSH and he presented a paper where he showed a 10-year series of 80% good results of tendon repair in no man's land. Dr. Harold Klein. Now, this was done with using modified Bunnell core suture in combination with the running Apitinon stitch with 6-0 suture. Aggressive program of rehabilitation using dynamic rubber band flexor tendon splinting produced results which were previously unobtainable. And this turned out to be a turning point in the history of flexor tendon repair. So much so that it caused a flutter among all the other famous and serious senior surgeons who were surprised to see, which was probably a village at that time, Louisville, producing a surgeon who is producing such good results. So these are some experts from the hand surgery in Louisville, written by Dr. Kleinert himself. So I'm just going to read that. Because I come from the Kleinert Institute, this is part of our legacy. Dr. Joseph Kutz became a hand surgery fellow in 1963 and my first partner in 1964. As a candidate member to American Society of Surgery of Hand in 1967, he was scheduled to present our 80% good to excellent result of the repair of flexor tendon in no man's land. The program chairman said that the paper was too controversial for a candidate member and I instead should end the paper. Following the presentation, one of the leading hand surgeons of that time stood up and stated, "I don't believe these results." He was invited to come to Louisville and review our patients. Hence, a committee of hand surgeons from ASSH was gathered and was sent to Louisville. The head of the committee was distinguished New York hand surgeon Dr. William Littler, who stated in his report, "If I injure a flexor tendon in a finger, I am getting on a plane and flying to Louisville. The nicest compliment and support one could wish for." So thus became the journey, and probably this is what put Louisville and Kleinert Institute on the map of hand surgery. In the last 3 decades, major advancements have been done in the field of flexor tendon repair, which are made with respect to the development of novel surgical repair techniques, accumulation of biochemical information regarding tendon repairs and gliding mechanisms, and modification of post-surgical rehabilitation methods and emerging trend of exploring biological to enhance tendon healing. So let us look into each of that. So first we'll look into some basic anatomy. As we know, there are 12 flexor tendons. There are 4 FDS, that is superficialis. There are 4 FDP, that is profundus. FPL, that goes for the thumb. FCR, that is flexor carpi radialis. FCU, flexor carpi ulnaris, and palmaris longus. So the FDS has separate muscle bellies which allow for independent finger flexion. They are all supplied by the median nerve. The small finger FDS is absent depending upon which population, racial population you're looking into. It's been reported absent from 0.2% to 21%. In carpal tunnel, the ring finger and long finger FDS are superficial to index and small finger FDS. So in the carpal tunnel, it kind of, if you could see my picture, it kind of has this orientation, whereas the ring and the small FDS are superficial and the index and the small finger FDS are deep. Coming to the FDP, now all except index finger come from a common muscle belly. FDP is used for power grip, and ulnar half is supplied by the ulnar nerve. So even if there is a high median nerve injury, the patient may be able to flex the ring, small, and even sometimes the long fingers And that's because of the common, the shared tendon of the FDPs. At about the level of superficial palmar arch, the lumbrical tendon originates from FDP tendons. So because of the presence of lumbrical attachments, it is believed that the FDP does not retract all the way back, whereas FDS can retract all the way back in case of zone 2 injury. There is an anomaly called as Lindbergh-Comstock anomaly, where there are tendinous adhesions between the FPL and the index finger FDP. So when the patient is asked to bend the FDP of the index finger, he also automatically flexes the FPL. The FPL tendon arises from the volar aspect of the mid portion of radial shaft and from its adjacent interosseous membrane. And finally, coming to palmaris, it's absent in about 15 to 20% of normal population. Wrist flexion power is not affected by absence of this muscle, and therefore this tendon is a common source for a tendon graft. So in the anatomy, there is a structure called Camper's chiasm. Now, as the tendons move from the wrist towards the finger, the FDS lies superficial to the FDP up to the bifurcation of the FDS. Now, after the bifurcation that happens at the mid P1 level, the FDS becomes two slips, and that courses laterally and then deeper to the FDP. And this FDS bifurcation happens in the A2 pulley area. This part of the FDS tendon also serves to constrain the FDP, similar to a pulley. And this fact is important. Like the splitting of FDS acting like a pulley is important, because some of the newer managements for trigger finger, they believe that if you could splint the DIP joint, that is to have a separate motion of the FDS and FDP, that can possibly prevent the locking or the recurrence. So this is one of the thoughts saying that this may be, in addition to the A1 nodule, the FDP under the FDS dynamic pulley may also be a reason for triggering. So deep to the FDP tendon, the FDF slip rejoin to form Camper's chiasm, and distally they insert onto the proximal and middle part of the P2 as two separate slips. So this is an anatomical dissection. Here you can see the FDS going all the way. They have actually split, and then they join back together. This is called Camper chiasm, and then it goes and inserts onto the middle phalanx. Pulleys, we have annular and cruciate pulleys. The annular pulleys are condensed, rigid, heavier annular bands. There are 5 annular pulleys. A2 and A4 are the most important. They maintain the anatomical path of tendons close to the bones, and they optimize the mechanical efficiency of digital flexion. Cruciate pulleys are cruciform, compressible. There are 3 cruciate pulleys, C1 to C3. They allow for digital flexion with condensation of the fibroosseous sheath at the inner part of the flexed fingers. This is called concertina effect. So this is when you open a finger, you will see the entire fibroosseous tunnel. But in reality, clinically, it is very difficult to identify the cruciate pulleys, like how they have given in these pictures. It's very, very difficult. However, the annular pulleys do stand out. As you can see, you have A1, A2, A3, and A4, and you can see a bit of A5 here. Thumb has 3 pulleys, A1, oblique, and A2. There are no cruciate pulleys for the thumb. A1 and oblique pulley are functionally important. Vinculae are, both the FDS and FDP have 2 vincula each. Vincula are like flimsy structures which contain the vascular supply. So each tendon has one short vincula called as vincula brevia and a long vincula called as vincula longus. So the vincula brevia is at the insertion. So for the FDP, it's at the FDP insertion. For the FDS, it's at the FDS insertion. The vincula longus comes little proximally. It is interesting to note that the vincula longum of the FDP is actually the continuation of vincula brevia of the FDS. So how does the tendon derive its nutrition? So flexor tendons derive nutrition both from synovial and vascular sources. So the flexor tendon outside the synovial sheath. So I showed you the picture where all the pulleys and were present. There is a synovial sheath covering the tendon at that level almost up to the level of A1. So till in that area, the flexor tendons are supplied. Outside of that area, the flexor tendons are supplied by the vascular supply through a paratenon, and vascular supply plays an important role for nutrition in that area. However, within the synovial sheath, they are mostly deprived of vascular network. Only limited dorsal region are supplied by the vincula, as mentioned before, and the intrasynovial flexor tendon are mainly nourished by synovial fluid. So Worden described 5 zones of flexor tendon. So zone 1 starts from the insertion of FDP to the insertion of FDS. Excuse me. Zone 2 starts from the insertion of FDS to the deflection of A1 pulley. Zone 3 starts from A1 pulley to distal margin of transverse carpal ligament. Zone 4 is the area under the transverse carpal ligament, and zone 5 is proximal to transverse carpal ligament. So it's important to note that in zone 1, there is only one tendon, that's FDP, whereas in zone 2 and proximal, there are 2 tendons each. Among this, the zone 2, as mentioned before, is the most difficult and previously called as the no man's land zone. Zones in the thumb distal to the IP joint is zone 1. From IP joint to A1 pulley is zone 2. The area of thenar eminence is zone 3, and the zone 4 and 5 are the same. Elliott and Moyman have further classified zone 1 into 1A, 1B, and 1C. 1A is the very distal of FDP tendon. 1B is from 1A to distal margin of A4 pulley, and 1C is under the A4 pulley. Tang has classified zone 2 into 4 categories, and this does have clinical significance, which I will come to later. 2A is the area of FDS insertion. 2B is from the proximal margin of FDS insertion to the distal margin of A2 pulley. So this is 2A, where the FDS inserts. From the area of FDS insertion till A2 is 2B, and under the A2 pulley is 2C, and proximal to that is 2D. So flexor tendon, after an injury, it heals by intrinsic and extrinsic mechanisms. Intrinsic healing takes place through proliferation of tenocytes and production of extracellular matrix by intrinsic cells. Extrinsic healing takes place when cells from outside the tendon come and contribute in healing. So growth of tissues or cells seeding from outside the tendon. The tendon's intrinsic healing capacity is innately weak, and extrinsic healing becomes dominant when the intrinsic capacity is disabled, such as severe trauma or to the tendon or peritendinous tissues or post-surgical immobilization. Now this is important if you think like how the tendon was damaged. If the tendon was damaged by a clean knife cut injury, so you can expect that there will be tenocytes on both sides of the tendon and they'll contribute to healing. Whereas if a tendon has been damaged by, let's say, a table saw, then the tendon ends would be ragged. You will not have good tenocytes there. There will be overlying much extrinsic healing going on, and that will lead to a poor outcome because of adhesions. Now, tendon healing exclusively through intrinsic mechanism occurs only in experimental condition. In reality, tendon heals through a combination of both intrinsic and extrinsic mechanism. The balance depends upon the condition of the tendon and surrounding tissues. Extrinsic healing does not mean it is always leads to adhesions. However, extrinsic healing can lead to restrictive adhesions that hampers tendon function. So in order to know that, we have to know what are like the grades of adhesions. Grade 1 is no adhesions. Grade 2 is flimsy adhesions, such as visible flimsy membrane tissue from tendon to outside tissues. 3 are loose adhesions. These are loose and largely movable. 4 are moderately dense adhesions with limited mobility, and 5 are dense adhesions. Now you will really get experience of this when you go back either to remove a hardware or in order to a tenolysis. You will see these varying grades of adhesion. Some adhesions are really dense. They go up to the bone down there, and you really have to struggle to release the tendon in such cases. Whereas sometimes you will see there are adhesions, but that need not necessarily hamper the tendon gliding. So the essence of the story is that adhesions are not necessarily bad, but it is the dense adhesions that is what we have to prevent. Adhesions which arise from bone, periosteum, or major annular pulleys are dense, and there are multiple strategies have been attempted to reduce these adhesions, such as medications, artificial barriers, chemical molecules. But so far, the only two things that are known to reduce adhesion, one is meticulous surgery, and second is early postoperative motion. Now, so let's come to the biomechanics of tendon repair and gliding. During normal hand action, the forces generated in the tendon vary from 1 to 35 Newton. So a surgically repaired tendon should be able to withstand a tension of at least 40 Newton. The repair should be able to withstand cyclical loads under both linear and curvilinear load conditions. A conventional two-strand core repair plus running peripheral sutures yield a maximum strength of 20 to 30 Newtons. Jorge, can I just come back in a couple minutes?
Yes.
Yeah, yes.
Yes, sir.
I'm sorry, but someone is at the door. I'm just going to check on that. I'm sorry.
Thank you. No, you're good.
Okay, I'm sorry about that. So, yes, let me continue. So as I was mentioning, a two-strand repair will give a tension of 40 Newtons. A two-strand repair gives a tension of about 20 to 30 Newtons, which is not adequate. A four-strand repair, on the other hand, gives a strength of 40 Newtons, and a six-strand repair gives a strength of 50 to 60 Newtons. So based on this, we should have at least four-strand or more repair needed for a good tendon repair, which will withstand the normal hand action. So there are many factors that affect a surgical repair. The number of suture strands, as I mentioned before, the strength is roughly proportional to the number of core sutures. The tension of the repair, a slight tension is necessary on the repair to prevent gap formation. The core suture purchase, that is when you're taking a stitch from the cut end of the tendon, how much proximally or distally you go, that is the core suture, and it should be at least 0.7 to 1 centimeter. The type of suture junction, locking is better than grasping. I will explain that in the next image. The diameter of suture locks should be at least 2 millimeters. The suture caliber should be at least 4/0 or 3/0 sutures, and the material property of suture materials. Peripheral sutures, they serve to tidy up and approximate the tendon. They also add to the strength of the repair. The deep bites increase the repair strength. The curvature of the gliding path, the repair strength decreases as the tendon curvature increases. And the holding capacity of the tendon, that is basically how good the tendon is. Like a shredded tendon by table saw injury will not hold as good as a clean cut knife injury. So this is just a table that demonstrates what all factors contribute to the surgical strength. The core sutures depend on the strands, the purchase length, tension, material, suture caliber, whether it's locking or grasping type. and the peripheral suture, number of runs, suture purchase, caliber and tension, the material properties, the curvature, and the holding capacity. So as I mentioned before, the surgical repair in a tendon under curvilinear load is weaker than a linear load. The repair strength decreases as the curvature increases. The repair fails more easily in flexed finger under curvilinear loads. What about a tendon that is cut obliquely? So we analyzed this last year in a cadaver tendon, and we noticed that the tendon that is cut at 90 degrees demonstrate higher overall gapping and breaking strength that was statistically significant when compared to obliquely cut tendons. And this is accepted in the Hand New York and should be published soon. Tan and Tang also recommend a greater core purchase and locking repair for obliquely cut tendons. Next, coming to pulley venting. Now, annular pulleys are critical to the function of digital flexor tendons. Lengthy loss of sheath and pulleys cause anterior displacement or bowstringing of the flexor tendon during finger flexion. In the finger, A2 and A4 are the most critically located and functionally important. Preservation or reconstruction of the tip pulley is considered is necessary in the absence of other pulleys or sheath. Now, this is important to note that if one pulley is lost, even if it's A2 or A4 and the other pulleys are okay, then that will not have a detrimental effect. So the concept that one pulley is more important than the other is not actually correct. It is the total accumulation of the sheath pulley, how much of that is released. That's what affects the outcome. Incision of 2/3 of A2 or entire A4 of the pulley results in no tendon bowstringing or little loss of digital flexion. In vivo settings, incision of A2 decreases resistance to tendon motion and lessens the chance of a repair failure. So the overall loss of less than 2 centimeters of sheath pulley, even including A2, has no substantial mechanical consequence. So let's say if you are releasing here, you can release the entire A4 part of C2. If you are releasing here, you may release a significant portion of A2, and that is okay. If the injury is there and you have to release it, that is okay as long as the total cumulative release is less than 2 centimeters. A similar observation was I had noticed when doing a cadaver study on the extent of A1 and A2 release on the impact of tendon subluxation and bowstringing. So again, similar observation when I sequentially released, I started releasing A1 and then released 25% A2, 50% A2 and complete 100% A2. And I noticed that there was no bowstringing when only A1 was released. When A1 and 25% A2, again, no bowstringing. A1 and 50% of A2, bowstringing was observed in about 3 out of 48, but there was no subluxation. Only when complete A1 and A2 were released, we noticed bowstringing and subluxation. So coming to the healing, following trauma and surgery, tendons undergo inflammation and edema. The volume of the tendon is increased, which increases the resistance within the narrow sheath. There is also subcutaneous edema outside the sheath that also impedes tendon motion. So these factors affecting resistance to tendon gliding should be considered in deciding how rigorous the postoperative motion program should be. The safety margin can be enhanced by strong surgical tendon repair and appropriately decompressing the tendon. Next, coming to the examination. Examination of flexor tendon is very easy. You just ask the patient if he's able to move his hands. For the FDP, we know the only tendon that moves the DIP joint is FDP. So you would want to block the PIP motion and ask to flex the hand, and you will see the DIP movement. It is common, as the FDPs are common tendon for all fingers except the index. It is common for the patient moving all the FDPs together or all the DIP joints together. FDS, on the other hand, have individual function. So you'll block all other fingers and ask the patient to move each finger individually, and that motion is by the FDS tendon. So after an injury, the timing, based on the timing, the surgery can be called a primary repair if it's done within a day. It can be called delayed primary if it's done within 3 weeks, or delayed repair if it's done after 3 weeks. Delayed primary repair produce results which are as good as primary repair. So flexor tendon injuries are not a true emergency, but they are urgent cases. So you should try to do them sooner the better. But again, it need not be done at the middle of the night. Now, under which anesthesia? Classically, it was initially done under general anesthesia, then it was moved to brachial plexus block, but both of them needed a tourniquet to be placed in the upper arm. The recent advance is Volant, which is popularized by Dr. Lalonde. So Volant allows the patient to actively flex and extend the operated digits. It enables surgeon to confirm that the motion is smooth, and it does not lead to gapping at repair site, and the repair strength is sufficient for early active motion on the operating table. So the surgeon can make these assessments on table itself. And when you are sure that the repair is strong enough, you feel comfortable to start motion early. So this is how I do. I do wide awake, but not in the traditional sense, which just giving local with epinephrine. I also give a wrist block. Dr. Lalonde does not advise a wrist block because he says that paralyzes the intrinsic muscles. However, the wrist block, you can get the hand numb in less number of injections, and then I just give local with epi for the involved finger, and it does not need so many sticks. There is no sedation. This is important if you're planning to do a wide awake surgery. It is quite common for the anesthesiologist to say, let me give some sedation, but some sedation actually produces more agitation and the patient is confused, he's moving around, he's not following commands. So that becomes more difficult. So I make a point to tell the anesthetist that we don't need any sedation. And keep the phentolamine available. Very rarely you may need it, but this was one case where I did it, and after doing the, I think this was a nerve repair, the finger turned blue and it stayed blue even and cold for the post-op area. I asked for phentolamine and I went and did my another case, and by the time I came back, his finger was fine. But just to have it if you are doing, especially in outpatient settings, because you cannot send a patient with a finger like this. So the wound should be thoroughly debrided, devitalized tissue excised, and the wounds washed. So there is no compromise in these aspects. If the wound is really bad, you have to debride it. If the tendon is really bad, you have to you may have to sacrifice the tendon and come back and do a tendon graft at a later stage. You can do Brunner's incision or lateral incision. I prefer Brunner's incision in the fingers. So let us say, I'll give you a clinical scenario. There is a laceration on a finger here, and the patient has no sensation on this side. So technically you can make two types of incision. You can either start from this corner and make a zigzag this way, or you can start from this corner and make a zigzag this way. So which one would you prefer? I'm just asking a question to the audience. Would you prefer the blue one or the red one? Or makes no difference, depending on like what you feel that day?
¿Alguien quiere responder? I'm asking to the residents, Lax. Give me one minute, please.
Sure.
I believe the first one.
The blue one?
Yes, Nicolas is talking. I believe the blue one could help you to have better exposure of the collateral nerve to explore and see if there's a lesion, maybe.
Okay. Well, your answer is correct, but my reasoning for putting this incision is, if the patient has no sensation here, expect that artery is also probably cut. So you don't want a distal flap which is based on the injured artery. Like for example, this flap, if you would make an incision like this, then this flap is based on this artery which is cut here. So I would prefer to make the distal flap, like the proximal flap doesn't really matter because the arteries is fine till there. But the distal side, the flap should be preferably based on the artery which is intact rather than the flap based on the artery which is cut. Because what happens is then your circulation would kind of depend upon the collaterals, and it has to kind of come through the collateral here and perfuse it here. And that can make this tip jeopardize, and you can have a necrosis of that tip. So that's just one point. So let's come to the zone-wise injuries. Zone 1 injury, as I mentioned, only the FDP tendon is located in zone 1. When the tendon laceration is zone 1A or B, because of vincula attachment, both the proximal and distal end are easy to be found. When cut in zone 1C, the tendon may retract more proximally. Often it's necessary to make an incision to find the retracted proximal stump. In zone 1A injuries, the distal stump is very short and it can be fixed with a number of techniques such as a pull-out suture over a button, bone anchor, tendon sling, or transosseous fixation. So this was a patient I did with a let me, okay, this, can you hear me?
Yes, sir.
Hello, can you hear me?
Yes, Lax. Lax.
I don't know how to disable the audio. Can you hear me?
Yes, Lax.
Okay, sorry about that. Yeah, sorry about the audio. I don't know how to mute the audio. Okay, so that was the repair, and this is the post-op of that patient. So I assess the repair intraoperatively. That helps me start early therapy. So this was another patient whom I put a bone anchor. I know the bone anchor was a little bit too proud to my liking. She was a lady who had really small bones. So however, she did not complain about the bone anchor being prominent. So luckily that went well. Zone 2 injuries. Again, you need a 4O core that can, my preferred material is fiber loop, but any like even a Ticron or Ethibond would be just fine. The repair can be either a Kessler type repair, but there should be at least 4 core stitches. Psi repair, M-tang repair, and there are numerous repairs. So when I started, I used to do Kessler, then I transitioned onto Psi, and then currently I'm doing M-tang technique, and I'll explain to you why. And the epitendinous I put with 5-O-proline with the taper needle. It's important to use a taper needle and not a cutter needle, because multiple bites by a cutter needle can actually shred the tendon. It can be a simple running suture when the cut is sharp, like a knife cut, or you can put a silver sciol repair if it's a shredded injury, like a table saw injury. In order to retrieve the tendon, there are techniques. One technique is you can just with the pickup gently push the tendon under the pulley and the sheath until you retrieve it. You can also take a suture, a core suture from that, and pass the needle under the pulleys and retrieve it that way. And Arthrex also has a material called a tendon shuttle, which can be helpful in retrieving the tendon. So as I mentioned, there are multiple techniques. As you can see here, Bunnell, Suge, Cruciate, Savage, Suge, Strickland, Kessler, Becker. So after initially I was doing Kessler, and then I changed to Psi. And Psi technique I used to do for some time. It is a little complicated technique to mention. You need 2 sutures. You take like a transverse bite and you lock it. And similarly on the opposite side, you take a transverse bite, lock it, and then you pass both of them across. And after you pass both of them across, you take another transverse bite, and that makes it like, it becomes completely locked. It becomes like a frame that is completely locked. And then you come inside again and tie each other. It is cumbersome to do in a narrow space, That I would say is the most important drawback. And the other thing is it's completely like a locking stitch. Once you pass these sutures on either side, the frame is completely locked. And sometimes if there's a small gap of the tendon, it becomes difficult to achieve. And this is again, getting the tendon, the tension equally distributed over 6 strands become difficult. If your 2 strands are more tight compared to the other 4, then effectively this becomes a 2-strand repair and not a 6-strand repair. However, this is still I would say my preferred technique if the tendon cut is oblique. So this is what I do right now. It's called M-tang repair. So I start on the one end, I pass it across and I lock it. Then I come out through the center of the tendon. And for this part, you can consider it somewhat similar to a Kessler. I go out, come transversely, come back inside, and come out here. Now the original description is you tie the suture here and you take another suture material. However, I use a modified version of it where I go back in with the same suture and tie it in the middle. So let me show you the video. I apologize for the PowerPoint. Let me go back. In that video, I've actually passed it to here, pass it across, and I've come out till here. So this much is already done in that video. So I'm just going out through the other side, and the next steps are in that video. Again, I apologize, not a good quality video. So I've already gone across, and now I'm coming back in. So this becomes like 4 strands, and this is where you lock it. So I'm locking it. So now you have 4 strands which are complete. For the 5th and 6th strand, I use the same suture and not necessarily a separate suture. I go in the middle, I cut one end, and need to edit it better. I go out through the cut end there. And I come back in from the same end, and I tie the knot in the middle. So that's how it's done. And this is the same patient on table. That this way we can even examine if there is if it's getting stuck in any of the pulleys, if there is any gap. So I found it very useful. And okay, I think I had a post-op of him somewhere. Okay, so this is another such patient, and I always take a video of that, because when the patient comes to post-op, I can show him, see, this is how you were doing, and that also motivates them to do it more. So that's the guy I just showed you. So more than 2 strands you need as a core repair. 4 or 6 strands is recommended. A certain tension you need, which can be roughly estimated as about 10% shortening. The core suture per stage should be about 7 to 10 millimeters. The locking tendon is much more secure than this sleeping one. And the diameter of the lock should be at least 2 millimeters or more. Again, 30 or 40 calibers, you can use variety of nylon or fiber wire. Simple or running peripheral sutures, and minimal separation of stitches of peripheral sutures if core repair is extremely strong, and avoid extensive exposure of sutures over the tendon surface. I think this was probably done with the Jorge. I don't know if Jorge remembers this. So and that's her follow-up. So I had initially mentioned about the 2 areas of FD, the 4 sub classification of zone 2s by Tang, like 2A, 2B, 2C, and 2D. So what are the clinical significance of that? The clinical significance is that in 2A area, where the FDS, that's the FDS insertion area, you may have to put like an anchor to insert the FDS. In 2B, there are 2 slips of the FDS, which are dorsal to the FDP. And you may be able to repair over there. Whereas under the A2, that is 2C, you may want to resect the FDS and or maybe repair only 1 slip in order to reduce the bulk. Whereas proximal to A2, that's 2D, you may be able to repair just like zone 3. This is another. This intraoperative repair. And that's this is the post-op. This guy is probably early post-op, and he would still need, he still has does not have good range of motion. So for zone 3, 4, and 5, the techniques are almost identical to zone 2. These zones have a better prognosis because of richer vascularity. Remember, beyond the flexor sheath, they have paratendon, and the vascularity is better. Adhesions in these areas are less likely to impede tendon motion. And remember, zone 4 flexor tendon may be accompanied by median nerve injury, and for that you may have to either partially or completely open the transverse carpal ligament. Zone 5 is called as a spaghetti wrist, which because of the multiple tendon injuries and also along with the neurovascular, so everything looks like noodles or spaghetti, it does have poor outcome. So when encountering a zone 5 injury, how can you identify tendons? That was a little difficult in the beginning of my residency, but I learned that the FCR has a flat tendon and it also has its own sheath. That way you can identify it. FCU is a thick tendon and it has muscles all the way to it till very distally. FTS have separate tendons, but they vary in size and in their orientation, which I mentioned before, that the ring and long FDS are more superficial. The FDP are deeper, and except the index, all the FDPs are stuck together. So they look like multiple slips which are stick together. FPL has the same plane as FDP, so it will look like FDP of index. The FDP of index and FPL are lying side by side. It's just that their muscle bellies are in opposite direction. And palmaris is a superficial, small, flat tendon. What to do if there are partial tendon laceration? If the laceration is less than 60%, that does not necessitate a repair by core suture. For lacerations less than 60%, the tendon can be trimmed or to reduce the chance of entrapment. There is a risk of triggering entrapment or rupture if it's more than 60%. So the laceration of 60 to 80% requires at least a epitendinous repair or better a core repair. Alternatively, the cut portion of the tendon can be repaired with epitendinous stitches to smoothen the surface. If it's more than 80 to 90%, treat this as a complete laceration. However, we did a cadaver study, and in our study, we found that when we are doing gap formation, which was not assessed before, the gap formation happens even with 30% repair. 30% of laceration without repair, and rupture can happen with as much as 50%. So our recommendations are that if it is 50%, you should at least put a core suture, and if it's 30%, we should at least put a epitendinous suture. Coming to the rehabilitation, there are a lot of passive motion methods such as Kleinert, which is seldomly used now. Duran-Hoser, again, it's not very common. There are some combination of passive and active motion like Nantong regimen. Early active motion or Belfast method, this is what is more popular, and this is what we do. In the classic Belfast regimen, the splint is applied with wrist in mid flexion, MCP joint slightly less than 90-degree flexion, and IP joint straight. Light and the dressing is removed, and digit motion commences at 48 hours. And under supervision, exercise consists of 2 passive movements followed by 2 active movements at 2-hour intervals. However, in our institute, we follow something like a modified Belfast. And me personally, I put the splint with wrist in neutral and MP about 49-degree flexion and IP in resting position. And my mantra, which Dr. Lalonde told us, was that you should tell the patient that move it, but don't use it. So the patient should move his hand, but he should not use his hand. I typically start therapy on the 3rd or 4th postoperative day. I see the patient at 2-week follow-up. At 4-week follow-up, again, patient is re-educated and told if there's a lot of swelling, I recommend a pressure dressing, anti-edema measure desensitization. At 6 weeks, I would ask the therapist to start ultrasound. And if the patient is doing good at 6 weeks, we'll start load bearing. So this was another flexor tendon injury which was done, which was repaired, and this is his outcome. So you can see, so at one time a zone 2 injury was told as no man's land, and was even till the greater part of 19th century, we had recommended not to repair it, but we have come a long way from that to getting a result like this. So that's it. So thank you for your time. And I really appreciate this opportunity, which was given by my dear friend, Jorge. And I'm open to any questions, comments, or even advice from Dr. Moreno.
Thank you, Lax. Thank you for a wonderful talk. And what a great case you have. No sé si alguien tiene alguna duda, pregunta.
Do you have in the patient that you show us, do you use Supramid?
I use fiber loop.
Or do you use fiber loop?
Fiber loop is basically
the fiber loop is fiber wire,
but the loop, yes.
The fiber wire with the loop.
Yes.
No.
Yes. Yeah, that's correct.
But you know, here I don't know if it happens there, but here in Colombia, We have that, but they come with a very big needle, like a very fat needle, or like a ¿cómo se dice? Gorda.
Thick.
Like
Broad.
Yes. Yes, we have two needles. The one you say is the one you said, which is very thick, like, very difficult to pass. But there is one more needle which is nice. I can send you the photos. I can send the photos to Jorge of both.
Please.
Yes.
Please, because we can ask the people from Artrex to bring us that with the other needle.
Yes.
And
sure.
No, thank you, Dr. Bandari. It was a very nice talk, and I'm sure that our residents enjoy it. You cover everything, so I just appreciate it. So thank you for your time, or for
no problem.
shared your experience with us.
No problem. Thank you. Thank
Okay.
you so much. One more thing I just want to tell you was
somebody else.
Yeah, at about 6 weeks, if the patient still has like a PIP little contracture, I immediately start on what's that? I just forget the name.
With a splint.
Yeah, with a splint. It's not a
joint jack.
No, not a joint jack. The other one.
Like a joint jack? No.
Yeah, something like a joint jack.
The stack one?
Which has a spring and which makes it straight.
The one with the yeah.
Yeah, with the spring and
makes that is not a joint jack with a screw, but with the spring.
With the spring, yes. I use that, and I discontinue splint at 6 weeks.
Okay. Okay. Thank you again. You are so young, so you didn't have the opportunity to know Dr. Kleiner, but I just want to show you my best picture with him. I was there in the operating room, and he was looking at me. That's a wonderful picture. So I just want wanted to share that with you. Okay.
Yeah.
Well, thank you again.
Yes.
I don't know if anyone have another question. ¿Alguien tiene alguna otra pregunta?
I would be happy to answer any questions from residents.
I have another question, Dr. Bandari.
Yes.
How often do you decide to make an allograft? And the other question, secondary to that, is how does the rehabilitation protocol change when you use an allograft and when you make a primary repair?
You mean the tendon allograft? You're talking for the tendon? No, yes. I have never had to use one for a tendon allograft so far. So I have been able to get a primary repair. There is one patient of mine who had a very bad crush injury, and if at least in zone 2 or flexor tendon, what you would need is you need to put Hunter rods and do like a staged reconstruction. So I put Hunter rods in her if the injury is so bad, and then come back later and put a tendon graft. And I would use the patient's own tendon graft, such as palmaris or plantaris. So I've not used allograft for the tendon of the hands.
Let me explain something, Dr. Bandari. Nico, y todos. En reparaciones de flexores rara vez se utilizan aloinjertos. Eso no realmente muy rara vez se utiliza, porque existe para poder hacer una reparación secundaria de flexores, es decir, cuando uno necesita injerto porque no tiene suficiente cabo para suturar, uno puede usar, uno necesita hacer una reconstrucción en 2 tiempos. En 2 tiempos es utilizando unas barras de Hunter, como decía él, para volver a crear, digamos, el paso del tendón por entre el túnel osteofibroso, y después se utilizan injertos. Hay algunas personas que hacen reparaciones de tendones de mucho tiempo con defectos grandes en un solo tiempo, dependiendo de cómo esté la movilidad y esto. Sin embargo, digamos, lo clásico es que se utilizan unas barras de Hunter antes de hacer la reparación. sorry, I was just explaining the
Yes.
2 stages procedure.
Yes.
Because we also don't use also allograft almost. I haven't used it in my whole life.
Yes.
I don't know if my colleagues, but I'm not.
Yeah, me neither.
I haven't. Okay, well,
I have,
Nico, ¿tienes alguna otra pregunta?
Yes. Someone has,
Catalina.
No, no, señora. Muchas gracias.
Cata.
hi, Dr.
Okay,
Bandai.
Cata.
hello.
I had a question. How does
Yes.
your recovery procedure or protocol changes when there's vascular or nerve injury?
Yes. That's a very good question. Thank you for that. Now, it does not change actually. So at least my principle is that I should make the repair or reconstruction in such a way that it does not delay my therapy. So in order to do that, if the nerve repair, if I repair the nerve without much tension, and if need be, I will put a nerve wrap, like we have nerve wraps available. We wrap the nerve and we put a couple of stitches on both the ends. So that way the nerve doesn't dehisce when you're doing active motion. Similarly, when I do an artery repair, I do it as much as possible without tension. But if it's like a replant, and if there is need to be, I have no hesitation to take a vein graft. Like Dr. Ackland said, that the only time you hesitate, like the only time you waste in doing a vein graft is the time when you hesitate to take one. That's it. So if I think it needs a vein graft, I just go ahead and take a vein graft and I repair it. So in that way, I make sure both my artery and the nerve repair are stable enough to withstand therapy. So the starting therapy is very important, and that's why I make sure that both artery and nerve repairs are able to do it. And I just remembered the instrument is called as a Kapner. So we start a Kapner splint at 6 weeks if they still have any residual contracture. I just forgotten the name.
Okay. Well, thank you very much
Thank you.
for your time again.
No problem. It was a pleasure. Yes, I hope to meet you all guys soon.
I know.
If there is
Of
some
course,
meeting or
Lars.
anything.
Yeah, sure. You are very invited to Colombia.
Yes.
Jorge will take you all around.
Yes. Once
For
this,
sure,
for us,
Patron.
Well,
I'll do
thank
it,
you
man.
again for your time, and
I appreciate it. Yeah. Have a good
Lax,
night.
thank
have a
you,
good
hermano.
night.
Oh, you're welcome. Yeah.
Bye.
Take care. Bye.
Thank you and good night.
We'll see you soon, hermano. Take it easy, okay?
Yeah. Bye.
Bye. Thank you.